If we have patient on VV ECMO and the patient has cardiac arrest, so there will be complete loss of cardiac output, and the native heart is acting as a pump. However, with patient on VA ECMO, the ECMO circuit will provide at least partial circulatory support despite the arrhythmia, and the ECMO machine is acting as a pump. What are causes of arrest on ECMO? 4H and 4T. 4H is hypovolemia, hypoxia, hypothermia, and hyperkalemia. And 4T is like tension pneumothorax, which is not common actually in VA ECMO, but you can see it in patient on VV ECMO due to lung disease, tamponade, and maybe it will be common for patient on VV ECMO more than a patient on VV, especially if the patient is post-cardiotomy, thrombosis, MI, or pulmonary embolism, and toxin. Sometimes we should consider fulminant myocarditis, especially if the patient is on VA ECMO. If we have patient on VV ECMO and arrested, first we will call for help. Second, we will assess the circuit, and during assessment of the circuit, we will see the flow, the oxygen, the circulation, and if the patient needs respiratory support or not, then we will start chest compression, and we should consider if there is refractory arrest, we should convert VV ECMO to VA ECMO or consider it as ECPR. If we have patient on VA ECMO and the patient arrested, so what are the steps we are going to do? If the circuit flow can maintain systemic perfusion, for example, we have flow 4 liters per minute, so we have time to think about the problem and trying to solve the problem. ECMO and there is cardiac arrest and there is no flow. We should think about pump failure, and in case of pump failure, we should start to clamp the circuit, transfer the pump to hand cranks, and starting to ACLS protocol. For patient who has, if there is decannulation or circuit rupture, so we should compress and prevent bleeding and start also a CLS protocol. If there is air embolism, we should clamp the return line to prevent the air to diffuse into the patient and starting the same protocol of ECLS and compression. Pump head thrombosis, so we will clamp that circuit and starting also ECLS protocol. Compression. It should be done on patient for cardiac arrest on VA ECMO or shouldn't be done. If the circuit is able to maintain systemic perfusion, then we don't need to perform chest compression. But if there is pump failure, we should switch to hand crank immediately. If there is no circuit flow, then we should manage as per CLS protocol until the ECMO flow is re-established again. If there is VA ECMO and cardiac arrest, so how is the pulse? There will be loss of pulse, arterial pulsation, due to loss of native cardiac output. So it will result in a flat arterial line, and we will see as here that there is mean arterial blood pressure, which will depend on amount of ECMO support and the patient's total peripheral resistance. So it will give a mean arterial blood pressure. What is the rhythm on ECMO? The rhythm will be shockable rhythm as ventricular fibrillation, or non-shockable rhythm as systole or VE, pulseless electrical activity. The patient who has severe cardiogenic shock may not have palpable pulse or visible pulse on their arterial line trace. While this would be technically difficult to fit the definition of PA, so sometimes echo may show some cardiac movement in this setting. Loss of pulse will reflect severe heart failure rather than arrest. When managing cardiac arrest patient on VA ECMO, what we should do? First, we should get help. Ensuring that ICU consultant is present, ECLS coordinator or perfusionist are notified as soon as possible. We should decrease lung ventilation. Pulmonary blood flow is usually minimal, so the required respiratory rate should be 2 to 4 breaths per minute during cardiac arrest on VA ECMO. After reverting the patient or restoring ROSC, so we should adjust the ventilator. ECMO blood flow setting should be adjusted. Inotropes and vasopressors also need to be adjusted and revised. It's very important to note that patients who are receiving via ECMO sometimes this patient to be awake. So at least during cardiac arrest, we should consider the need for explanation and their need for analgesia and sedation before giving uncomfortable therapy intervention as giving DC shock for them. Complication with the loss of native cardiac output. We should know that if even the patient has full ECMO support, there will be lack of forward blood flow through the left ventricle, so that will result in stages of the blood in left ventricle. So thrombosis occurs when forward blood flow and aortic opening not restored in a timely fashion. Prolonged impaired pulsatility can also lead to progressive left ventricular distension and potential aortic regurgitation, which can cause acute pulmonary edema. So that will lead to VA ECMO support will be ineffective. Besides ELSO Red Book, this is a reference of this lecture. Thank you, and I can receive your questions and comment in blue in the comments.